I want to talk today about a deficiency that I think is the single most consequential misdiagnosis in older adults. And I don't say that lightly. Vitamin B12. And I want to open with the reason it matters more than most nutritional deficiencies you could name. If you are low in most vitamins, you feel unwell, and when it's corrected, you recover completely. B12 is different because it is essential for maintaining the myelin sheath, the insulating layer around your nerves. And when B12 runs low for long enough, that insulation degrades and the nerves themselves are damaged. And here is the crucial part. That nerve damage is largely reversible if it is caught within the first months and becomes permanent if it is left for years. So with this particular deficiency, time is not neutral. Every month that a low B12 goes unrecognized, a little more of the potential recovery is lost. And the reason it is missed so often is a cruel combination of three things. First, its symptoms are, almost without exception, the things everyone expects from aging: tiredness, unsteadiness, forgetfulness, tingling feet, low mood. Second, the classic teaching that B12 deficiency causes anemia has misled generations, because a substantial proportion of people with B12-related nerve damage have a completely normal blood count. So a normal full blood count does not exclude it. And third, the two medications that most reliably deplete B12 are among the most prescribed drugs in the world and are taken by an enormous number of the very people at risk. So today, I'll give you the 9 signs, explain exactly why older adults are so prone to this, name the medications, explain the testing properly, including its genuine limitations, and tell you what treatment involves and how quickly things improve. Let's begin with what B12 actually does. Let me explain what B12 is for, because it explains every symptom. Vitamin B12 is essential for 3 things. It is required to make red blood cells, which is why deficiency causes a particular kind of anemia. It is required for DNA synthesis, which affects all rapidly dividing cells, including those lining your mouth and gut. And, most importantly for this video, it is required to build and maintain myelin, the fatty insulating sheath that wraps your nerves and allows electrical signals to travel quickly and accurately. Without adequate B12, that insulation deteriorates, and the nerves affected first are, as I explained in my neuropathy video, the longest ones, which run to your feet, and the ones in the back part of your spinal cord that carry position sense, which is why balance is affected so characteristically. Now, why are older adults so prone? Because absorbing B12 is remarkably complicated. It requires adequate stomach acid to release B12 from the protein in your food. It requires a substance called intrinsic factor made by the stomach lining. And it requires a healthy final section of the small intestine to absorb the resulting complex. And with age, several of those steps fail. Stomach acid production declines in a significant proportion of older adults, a condition called atrophic gastritis. So B12 cannot be released from food even when the diet is perfectly adequate. Intrinsic factor can be attacked by the immune system, causing pernicious anemia, which is an autoimmune condition that becomes considerably more common with age. And intake itself may fall if meat, fish, eggs, and dairy are eaten less, which is common in later life. So B12 builds red cells, makes DNA, and maintains the insulation on your nerves. And older adults are prone to deficiency because the absorption process is elaborate and several of its steps fail with age. Now the 9 signs. Sign 1, fatigue and weakness, which is the commonest and the least specific, but which in B12 deficiency has a particular quality because it stems partly from anemia, so it comes with breathlessness on mild exertion, palpitations and pallor, and people describe a heaviness rather than sleepiness. Sign 2, and this is the most important sign in this entire video, tingling, numbness, or burning in the feet and hands, in the stocking and glove pattern I described in my neuropathy video, starting in the toes and creeping upward symmetrically. This is peripheral neuropathy from myelin damage, and it is the sign that must not be ignored, because it means nerve damage is already occurring and the clock is running. Sign 3, and this is the one that is most specific to B12 and most often missed: unsteadiness and balance problems, particularly in the dark. Here is why that detail matters so much. B12 deficiency damages the back part of the spinal cord, which carries position sense from your joints and feet, so your brain loses its sense of where your legs are. In daylight, your eyes compensate and you manage. In the dark, or with your eyes closed in the shower, that compensation disappears and you sway or stagger. So a person who says they are fine walking about but feel dreadfully unsteady in the dark or when washing their hair with their eyes closed is describing something quite specific, and it points at the spinal cord. Sign 4. Memory problems, poor concentration, and mental fog, which I listed in my memory video among the reversible causes that must be excluded before anyone concludes anything, and which in severe cases progresses to genuine confusion. So the first 4 signs are fatigue with breathlessness and pallor, tingling in the feet and hands, unsteadiness that is markedly worse in the dark, and memory and concentration problems. Sign 5. Mood changes, meaning low mood, irritability, and in some cases genuine depression. And there is a recognized association between low B12 and depression in older adults, which is another reason it belongs in the workup of a person presenting with low mood. Sign 6, the mouth and tongue, and these are visible so they're useful. A smooth, shiny, red, and often sore tongue, which happens because the surface papillae flatten when the tissue cannot renew properly, and which I described in my tongue video as one of the classic findings, alongside mouth ulcers and cracks at the corners of the mouth. Sign 7, pale or slightly yellow skin, and this pairing is characteristic and worth understanding because B12 deficiency produces both pallor from anemia and a mild yellow tinge from the breakdown of fragile red cells that die prematurely. So the classic description is a lemon yellow pallor, and it may be visible in the whites of the eyes. Sign 8, visual disturbance, which is less common but worth knowing because the optic nerve can be affected, producing blurred or reduced vision. And sign 9, digestive symptoms, meaning loss of appetite, nausea, constipation or diarrhea, and weight loss, which occur because the rapidly dividing cells lining the gut are affected. And I'd add one more that isn't strictly a symptom, but is a genuinely important clue. If a blood test has ever shown that your red blood cells are larger than normal, which is reported as a raised MCV or as macrocytosis, that is a classic pointer to B12 or folate deficiency and should always be followed up. So signs 5 to 9 are low mood, a smooth, sore red tongue with cracked mouth corners, a pale lemon-yellow tinge to the skin and eyes, occasional visual disturbance, and digestive symptoms, with enlarged red cells on a blood test as a strong laboratory clue. Now let me give you the causes, and I want to start with the medications because they affect so many people watching. First, metformin, taken by an enormous number of people with type 2 diabetes, which interferes with B12 absorption in the small intestine, with the risk increasing with dose and duration. So someone on metformin for 10 or 15 years is at genuine risk. And I described the trap in my metformin video, and I'll repeat it because it is so important. A person with diabetes who develops tingling feet has it attributed to diabetic neuropathy, which is entirely reasonable since diabetes is the leading cause. So nobody checks the B12, and a reversible cause sitting on top of an irreversible one is missed for years. Second, the acid-reducing medications, meaning the proton pump inhibitors like omeprazole and lansoprazole, and, to a lesser extent, the H2 blockers, because stomach acid is required to release B12 from food, so years of acid suppression reduces absorption. And this matters enormously given how many people take these long-term without review. And note that these two combine, so a person on metformin and omeprazole, which is an extremely common combination, has two independent mechanisms working against them. Beyond medications, the other causes are these. Pernicious anemia, the autoimmune attack on intrinsic factor, which is the classic cause, and which becomes more common with age. Atrophic gastritis with reduced acid, which affects a substantial proportion of older adults. Previous stomach or bowel surgery, particularly anything involving the stomach or the last part of the small intestine, and this includes weight loss surgery. Celiac disease and Crohn's disease. Bacterial overgrowth in the small intestine. Excessive alcohol. Nitrous oxide exposure, which is relevant for anyone who has had it repeatedly. And dietary inadequacy, which matters particularly for vegetarians and vegans, since B12 occurs naturally only in animal products, and for older people whose diets have narrowed. So the medication causes are metformin and long-term acid suppression, and the medical causes are pernicious anemia, low stomach acid, gut surgery and gut disease, alcohol, and a narrowed diet. Let me now talk about testing, because this is genuinely more complicated than it should be, and knowing about it helps you. The standard test is a serum B12 level, and it has real limitations. First, the reference ranges vary between laboratories, and the lower end is set by population averages rather than by what your nerves need. So results in the low normal range, meaning roughly between 200 and 350, are a genuine grey zone in which many people are symptomatic. Second, the test measures total B12, most of which is bound to a protein and unavailable to your cells, so it can appear adequate while the usable fraction is low. Third, and importantly, a normal blood count does not exclude deficiency because the neurological damage can occur without anemia, and this is the single most common reason it is missed. So what should happen if your level is borderline and your symptoms fit? There are two additional tests worth knowing about: methylmalonic acid, or MMA, and homocysteine, both of which rise when B12 is functionally deficient at the cellular level, and MMA in particular is regarded as the more useful confirmatory test. So the sentence worth taking to your doctor is this: my B12 is in the low normal range and I have these symptoms. Could we check my methylmalonic acid, or could we consider a trial of treatment? And there are two more tests to know about: folate, which must be checked alongside B12 because the two interact, and because treating folate deficiency alone in someone who is also B12 deficient can worsen the neurological damage, and intrinsic factor antibodies, which identify pernicious anemia and which matter because that diagnosis means lifelong injections rather than tablets, and also carries a slightly increased risk of stomach cancer requiring awareness. And one practical caution: if you have already started taking B12 supplements, testing afterwards is unreliable, so ideally, test first. So the standard test has real limitations. A normal blood count does not exclude deficiency. Borderline results with symptoms deserve MMA testing or a treatment trial, and folate must be checked alongside. Let me talk about treatment, because there are two important things to know. First, the route. The traditional treatment is intramuscular injections of hydroxycobalamin, typically a loading course of several injections over 2 weeks, then maintenance every 2 or 3 months. And for people with pernicious anemia or absorption problems, this remains the standard because it bypasses the gut entirely. But here is something worth knowing. High-dose oral B12, typically 1,000 micrograms daily, is effective for many people even with absorption problems because a small proportion of B12 is absorbed by simple diffusion independently of intrinsic factor, and studies have found oral treatment comparable to injections for many patients. So if injections are difficult for you, that is a legitimate conversation. Second, and this is what people most want to know, how quickly do things improve? The answer differs by symptom, and understanding this prevents disappointment. The blood abnormalities correct within weeks. Fatigue and general well-being often improve within days to weeks, and people frequently describe this as dramatic. The tongue heals within weeks. But the neurological symptoms, the tingling, the numbness, and the unsteadiness, improve slowly over months, with the greatest recovery in the first 6 months and continued improvement possible for up to a year or more. And here is the crucial part. The extent of recovery depends heavily on how long the deficiency was present. Damage of a few months' duration usually reverses completely. Damage of several years may only partly reverse, and some may be permanent. That is the entire reason this video exists, and it is why I said at the start that with this deficiency, time is not neutral. And a note on maintenance. If the cause is permanent, such as pernicious anemia or previous gastric surgery, treatment is lifelong, and stopping it means the deficiency returns. So this is not a course to complete, but a replacement to continue. So treatment is injections or high-dose oral. Fatigue improves within weeks. Nerve symptoms improve slowly over 6 to 12 months, and how much recovers depends on how long it went unrecognized. Let me be very clear about who should be tested, because this is the actionable part. Ask for a B12 test if you have any of the 9 signs, and particularly if you have tingling in the feet, unsteadiness worse in the dark, or a sore, smooth tongue, which are the most specific. Ask if you take metformin, and ask again periodically, because guidance increasingly recommends periodic B12 monitoring in long-term metformin users. Ask if you take a proton pump inhibitor long-term. Ask if you have had any stomach or bowel surgery at any point in your life, including decades ago, because deficiency can develop years later, and these people are frequently lost to follow-up. Ask if you have another autoimmune condition, particularly thyroid disease, type 1 diabetes, or vitiligo, because pernicious anemia clusters with them. Ask if you have unexplained anemia, and specifically if your red cells are enlarged. Ask if you are being investigated for memory problems, because, as I said in that video, B12 belongs in that panel and often is included, so check what yours showed. Ask if you have unexplained neuropathy, low mood, or balance problems. And ask if you eat little or no meat, fish, eggs, or dairy. So the people who should specifically request this test are anyone with the specific signs, anyone on metformin or long-term acid suppression, anyone with previous gut surgery or autoimmune disease, anyone being investigated for memory or balance problems, and anyone with a restricted diet. Let me be clear about when to see a doctor and with what urgency. See your doctor promptly, meaning within weeks rather than months, if you have tingling or numbness in your feet or hands, if you have new unsteadiness, particularly in the dark, if you have a sore, smooth, red tongue, or if you have unexplained fatigue with pallor or breathlessness, and use the specific words, "Could I have my B12 and folate checked?" And if the B12 is low normal, could we check methylmalonic acid? And I want to explain why I say promptly rather than urgently, because it is not a same-day emergency, but it is a condition where months genuinely matter for how much recovers, so it deserves more urgency than most people give it. Seek prompt assessment too, if you have rapidly progressing weakness or numbness, if you have difficulty walking, if you have any bladder or bowel changes alongside neurological symptoms, or if you have significant confusion, since severe deficiency can cause marked neurological and psychiatric symptoms. And there is one specific caution worth knowing. If you are found to be deficient in both B12 and folate, the B12 must be treated first or at the same time, never folate alone, because correcting folate alone can mask the blood abnormalities while allowing the neurological damage to continue. And this is a genuine and recognized error. And do not simply start high-dose supplements before testing if you can avoid it, because it makes the diagnosis and the identification of the underlying cause much harder. And identifying the cause matters, since pernicious anemia means lifelong treatment. So go promptly rather than urgently. Ask for B12 and folate together with MMA if borderline. Treat B12 before or alongside folate and test before supplementing. Let me paint you 2 pictures. First, picture a woman of 74 with type 2 diabetes who had taken metformin for 13 years and omeprazole for 9. Over about 3 years, she had developed tingling in her feet, which was put down to diabetic neuropathy, an unsteadiness that was worst getting up in the night, which was put down to her age, a persistent tiredness, which was put down to her diabetes, and some memory fogginess, which her family had begun to worry about privately. 4 separate symptoms, 4 separate reasonable explanations, and nobody had connected them or ordered one cheap blood test. Her B12 was significantly low, which was entirely predictable given 2 medications that each independently reduce absorption. Treatment improved her energy within a fortnight and her mental clarity over a few months, and it stopped the progression of her neuropathy. But the tingling in her feet only partially resolved, because 3 years is a long time for myelin to go without maintenance. That is the story I most want to prevent, and the whole thing turned on a test that costs very little. Second, picture a man of 69 who noticed he was becoming unsteady in the shower when he closed his eyes to rinse his hair, and who mentioned this specific detail to his doctor, which was clever of him, because that particular symptom points at the spinal cord rather than at the inner ear or the legs. His B12 was low normal, in the grey zone, and because the symptom was so characteristic, his doctor checked methylmalonic acid, which was raised, confirming a functional deficiency. He was treated, and because it had been caught within months rather than years, his balance recovered completely. 2 people, and the difference in outcome was measured in how long it took somebody to think of the test. And let me speak briefly to those caring for or close to an older person. This is the deficiency worth being persistent about, because the symptoms are all individually attributable to aging and only make sense as a group, and you are far better placed to see the group than they are. If they take metformin or an acid-reducing tablet long-term, ask when their B12 was last checked, and if the answer is never, which it very often is, that is your prompt. Watch for the specific signs rather than the vague ones, so the tingling feet, the unsteadiness in the dark or with eyes closed, and the sore, smooth tongue, because those are the ones that point specifically here. If they are being assessed for memory problems, make sure B12 is part of that panel and ask what the actual number was rather than accepting that it was fine, because low normal results get reported as normal. And be persistent about the grey zone, because a result of 240 with tingling feet and unsteadiness is not a reason to stop looking. It is a reason to ask for the confirmatory test. Let me draw this all together. Vitamin B12 maintains the insulating sheath around your nerves, and that single fact is why this deficiency is different from others, because prolonged deficiency causes nerve damage that reverses well if caught within months and may be permanent if left for years. Its 9 signs are fatigue with breathlessness and pallor, tingling and numbness in the feet and hands, unsteadiness that is markedly worse in the dark, memory problems and mental fog, low mood, a smooth, sore red tongue with cracked mouth corners, a pale lemon-yellow tinge to the skin and eyes, occasional visual disturbance, and digestive symptoms, with enlarged red blood cells on a blood test as a strong laboratory clue. It is missed constantly for 3 reasons, because every symptom is what people expect from aging, because a normal blood count does not exclude it, since the nerve damage frequently occurs without anemia, and because the 2 medications that most reliably deplete it, metformin and long-term acid suppression, are taken by enormous numbers of exactly the people at risk. The standard test has real limitations with a genuine grey zone, and borderline results with fitting symptoms deserve either a methylmalonic acid test or a trial of treatment, with folate always checked alongside and never treated alone. So here's what I'll leave you with. First, if you take metformin or a long-term acid-reducing tablet and have never had your B12 checked, ask for it this week, because those two medications plus the passage of years is the commonest setup for this there is. Second, learn the specific signs rather than the vague ones. And if you have tingling feet, unsteadiness that is worse in the dark, or a smooth, sore tongue, treat that as a reason to be tested promptly rather than eventually. Third, do not accept a low normal result as an answer if your symptoms fit, and ask the specific question about methylmalonic acid. Fourth, understand the clock, because this is the one deficiency where the delay itself causes the permanent harm, so months matter in a way they don't with most conditions. And fifth, if you are treated and it is due to pernicious anemia or previous gut surgery, understand that this is lifelong replacement rather than a course, and that stopping means it returns. There are a great many people who are tired, unsteady, foggy and tingling, who have been told each of those things separately is their age, and whose entire problem is a vitamin that costs almost nothing to measure and very little to replace, and whose recovery depends almost entirely on how quickly somebody thinks to look. So take care of yourself, count the signs, and go and ask for the test. And because diagnosing this properly requires blood tests and identifying the underlying cause determines whether treatment is lifelong, please treat these symptoms as your reason to see your own physician and request B12 and folate by name, and treat rapidly progressing weakness, difficulty walking, or bladder changes as reasons for prompt assessment. If this helped you, please give it a like and subscribe, because I share this kind of clear, practical guidance for older adults every week, and I'd love for you to keep watching with me.